We are going live in 3, 2, 1. You may start now, sir.
Good evening, ladies and gentlemen. A warm welcome to all of you. Welcome to probably the longest running academic web series in the field of neurology, episode 66th, 5.5 years old. We started during COVID time. Warm welcome to our faculty from Neel Ratan Sarkar Medical College, probably one of the oldest medical college in the country. And today's topic, a pediatric neurology topic, is excellent and very interesting. When headache precedes non-territorial stroke, an unusual pediatric mimic. All this has been possible the short time of 1 hour, keeping the whole case interesting, courtesy our program directors, who needs no introduction, and we are extremely grateful to them. Professor Dr. Lakshmi Narasimhan sir and Professor Dr. Sudhir Shah sir. So both our directors have guided us to keep their introduction extremely brief. On the same outset, I would also like to welcome Dr. Kartik Ghosh, Dr. Jashodhara Chaudhary, and Dr. Devashish Maiti, and we look forward for your interesting case presentation. Dr. Sudhir Shah sir needs no introduction. Sir is professor and HOD at prestigious Srimati NHL MMC and SBPI MSR Ahmedabad, and also director of neuroscience at prestigious Stirling Hospital. Recipient because of his work to mankind, clinical research and publications, and contributions to the field of neurology, Government of India bestowed prestigious Padam Shri to him. He is also a recipient of Bharat Gaurav Award at Senate of France, one of the highest international award by an Indian. Sir is also recipient of B.C. Roy Award, stroke, neurodegenerative disease, and epilepsy remains his areas of research and work. Our second program director, Professor Dr. Lakshmi Narasimhan sir. We need also no introduction. Professor Dr. Lakshmi Narasimhan sir is Director and Professor Department of Neurology at Sri Ramchandra Institute of Higher Education and Research, and he also built in Madras Medical College Department of Neurology. We all very fondly know him because of his excellent nurturing, coaching, and mentoring abilities for the DM students. Recipient of Paltussi Advisor from AN, A.B. Baker's Award for Global's Best Teacher, Best Paper Award, and many CMEs and conferences to Sir's credit. We are extremely grateful to both our program directors, whom you can see on the screen, Professor Dr. Sudhir Shah sir and Professor Dr. Lakshmi Narasimhan. May I request both our directors to have their pearls of wisdom and also introduce our participants for today's case study. Over to you, Sudhir sir and Dr. Lakshmi.
Sir is there?
Sudhir sir, you're on mute. You're on mute. Now we can hear you, sir.
Welcome all of you to this 66th episode of Secrets of Neurology, that is Knowledge Feast for all neurologists. And special thanks to NRS Medical College and Hospital Kolkata for accepting this lovely invitation at a relatively short notice. So thanks to Professor Kartik Ghosh and his team, Dr. Jashodhara Chaudhary and Dr. Devashish Maiti. We are very satisfied and we feel joyful to mention again that this series, Secrets of Neurology, has become a iconic series, and it has attracted attention of people not only from India but also from the nearby countries. And I suggest to all the medical students, specifically DM, DNB students, to regularly attend this webinar series and also retrieve from the YouTube all the episodes which are lying there. This is not only a great learning session, but also for students how to present cases and discuss all these things are also very important for students. And as per our feedback, it is not only the students, but many of the budding neurologists and even the seniors, they also have sent lots of appreciation, words of, kind words of appreciation from many of them. And they inspired us to continue this series, and that is the reason why we are on 66th episode. So, thanks to all the delegates and all those institutions who have participated so far. Also, a word of thanks to Globusel Division of Intas, headed by Mr. Arun Chadda, and the team here, Dr. Manoj and others, who have been very pivotal in networking and supporting the whole uh, knowledge series. With that, I would like to introduce today's speakers. May I have the first slide? Dr. Debashish Baiti will be presenting the case. As you know, the case is uh, very interesting headache with some stroke mimic in pediatrics. So Devashish is MBBS DCH, did MD Pediatrics, is DM resident in the Department of NRS Medical College, Kolkata. Just before a few minutes, we were discussing NRS Medical College is about 170 or 75 years old, one of the oldest existing medical colleges in India, maybe first or second in rank as far as the history goes. I'm told it is, I think, 175 years old. So, kudos to that institute. Next slide, please. Dr. Jashodhara Chaudhary, who is the assistant professor, she will be presenting the case for further discussion, dissection, localization, and giving all differential diagnosis, etc. She is MD Pediatrics, MRCPCH UK. She is DM Neurology, and she had done a fellowship in movement disorders at Nebraska. She is author of 32 publications, and currently, as I mentioned, she is assistant professor of neuromedicine at the hospital. She is secretary to Society of Pediatric Neurology and all. And she has so many other accolades. So next is Professor Karthik Chandra Ghosh, who will give the final pulse of wisdom. He is a professor in HOD. He's in charge of Movement Disorder Clinic and Memory Clinic, organizing secretary of Neurology Update Kolkata. He has almost 45 publications in national and international journals, and he has also served as a primary investigator in Association of Mitochondrial Gene in Alzheimer's disease conducted in ICMR project. So, with that brief introduction to all, once again, me and my co-director, Dr. Lakshmi, stand here with a grateful heart to all of you for supporting this noble cause of knowledge sharing, including all delegates and those who contributed to this webinar series. So with that, I hand over mic to Professor Karthik Ghosh to start the proceedings, please.
Good evening, sir. Firstly, my warm regards to Professor Sudhir Shah, Professor Lakshmi Narasimhan, sir. And first, I would like to thank to both of you for giving me this opportunity, giving us this opportunity to invite this good and beautiful and as well as excellent academic platform where our residents can join, and also we can share some our important inputs with you, like you people. That is what the oldest, and they are also the doyen of neurosciences, Professor Sudhir Shah, and also Professor Lakshmi Narasimhan, that, and both are very much respectful personalities in our neurology faculties. And so I would thank to also the Indus Pharmaceuticals for their giving this opportunity to share this platform for us. Thank you, thank you, sir. And this is my that is humble respect to both of you. Sir, in our today the session is a very beautiful case presentation, and this is a case which was admitted in our hospital uh, about 6 months back. And when this patient was admitted in our hospital, and we have thoroughly investigated this case and ultimately comes to a conclusion. And so this case, I think everybody should, especially all the delegates, those who are, and all the DM residents must know, particularly when a patient comes with severe headache, with holocranial, especially initially it's a holocranial headache, and sometimes there may be present with some recurrent stroke-like episodes. So, and also one episode of seizures. So, when this type of patients will come, we must know everything about this patients. So so Dr. Devasis, I think I would request to Dr. Devasis Maiti, our second year DM resident, he will present this case. And after the case was properly after the case, the discussions will be by by Dr. Yashodhara Choudhury. He is our colleague, and she will discuss everything about the differential diagnosis of the case. And me, lastly, I will also just conclude the session. Concluding remarks. Thank you.
Dr. Devashish, you can load the presentation and start.
Yes, I'm doing that, sir. So, am I audible, sir?
Yes, you're
Yes,
audible.
sir. So, good evening, my respected faculties and dignitaries of the Secrets of Neurology. I like to thank you all for letting me to present this case in this reputed platform. So, I am Dr. Devashish Maiti, the third year neurology resident of NRS Medical College. I will be presenting my case, which is when headache precedes the non-territorial strokes and unusual pediatric mimic. This is a story about a 10 years old girl who was admitted to another hospital, and the girl was born to non-consanguinity, and the girl was a second daughter by birth, and the other sibling was doing great. 3 months back, before the presentation to us, the patient had history of multiple episodes of non-bilious, non-bloody vomiting, along with mild rise of temperature, and on the very same day, the patient had holocranial headache, which was worse on lying down, and it was associated with bilateral visual dimness with colorful hallucinosis as described by the patient. On day 3 of the illness, the patient had sudden onset right-sided.
Sorry, sir, to interrupt you in between. Your slides are not moving, sir.
Sir, I'm not. This is the second slide, probably. Is it not moving, sir?
No,
No,
sir.
No
you
slides
make
are
a
moving.
full screen first. Can you make it full screen and then move?
Yeah, it has been already full screen, sir.
Sir, can you see the button share? Just click on that, close, and then reshare your screen.
Okay, I'm doing it again.
તમારા ખિસ્સામાં રહેલી 100 અને 500 રૂપિયાની નોટમાં મોટો ફેરફાર થવા રિઝર્વ બેંકે સૌથી વધુ વપરાતી આ બંને નોટમાં સુરક્ષા માટેના નિયમ
Full screen, please, Dr. Debashish.
Is it
If you
moving,
could.
sir?
No. You went off presentation.
First load the presentation and then do full screen and then move.
Okay, sir. I am doing it again.
Pratiksha, you also have this presentation?
Yes, sir, I have. Can I share it?
Dr. Debashish, are you comfortable if Pratiksha shares it?
Okay, please share, please, from your end, madam.
Yes. Give me a second.
It's okay. Okay, sir. No issues.
Yes, Dr. Debashish.
Okay. So I will be presenting this case from the second slide onwards, sir. Next
Second
slide, please.
slide.
So this is a story about a 10 years old girl who was admitted to another hospital. The girl was born to non-consanguineous parentage, and she was a second order by birth, and the other sibling was doing well. Episodes of vomiting, which was non-bilious and non-bloody. Along with that, the patient had mild rise of temperature, and on the very same day, the patient had holocranial headache, which was worse on lying down. And the patient complained that she had bilateral visual dimness with the colorful hallucinosis. And on the day three, the patient had sudden onset right-sided hemiparesis. But with the conservative treatment at that hospital, the patient started improving at the end of the first week, and with the gradual improvement, which was noticed for the next 15 days, the patient was absolutely fine. Next slide, please. Then 5 days before the admission, the patient had again recurrence of the symptoms like fever and vomiting, and along with that, the patient initially complained of an occipital headache, which in 2 to 3 days became holocranial and increased with the change in the posture of the head and the change in the posture of the patient, and the vomiting which the patient had usually caused transient relief from the headache episodes. Now, the patient also had the visual symptoms. She started to see some colored ball like items roaming in front of her eyes, which are vivid and colorful. And then, in again 3 to 5 days, the patient had dimness of vision in both the eyes, to both the near and the far vision. Then, on the day 5 of the illness, the patient had a left focal motor seizures, which of tonic-clonic type, which persisted for 5 minutes, and it recurred for several times during the hospital stay. And she was done a CT scan. On the findings of the CT scan, she was given some aspirin and protein pump inhibitor, and anti-seizure medications were given. And along with that, the antiemetics were also given, and the patient was subsequently referred to our center. Next slide, please. On examination, the patient was alert and oriented. The blood pressure was 105 by 69, and the mean arterial pressure was 80 millimeter of mercury, and all peripheral and central pulses were palpable. To say the mean arterial pressure of 80 at this age and for this gender was absolutely normal for the pediatric equivalents. The meningeal signs, we checked for the meningeal signs for the patient, which was absent, and the visual acuity of the patient will drop to the patient had absent projection of light sensation. The pupils were normal size and having normal pupillary reaction. And on fundoscopy, the D square normal, the foveal reflexes were present, but there was some vessel tortuosity. Mostly the arterial segments were tortuous. The extraocular movements were normal, and the patient had no ptosis, and no other cranial neuropathies were noticed. And patient had a clinically manifested weakness over the left side. And the deep tendon reflexes were 3 plus, and Babinski was positive over the both the sides. Next slide, please. So we started analyzing this case. Next slide. So initial complaint was headache. So initially it was an occipital location headache. So it might have staged or might have caused some irritation to the pain sensitive structure. So we localized this to the anatomical substrates of posterior fossa or the tentorial dural stretch, or the venous sinus pathology like the transverse or the sigmoid sinus could have been affected because of the disease. Then in 3 to 5 days it became holocranial. So it suggests that either there was a diffuse dural stretching or widespread venous congestion which was increasing the intracranial pressure. Now, we had two situations described with the headache. The first one is that the headache increases with the postural change. The headache gets worse on lying down. So, whenever the patient lies down and the venous return from the brain decreases, the intracranial venous pooling of blood occurs, and it reduces the CSF absorption, letting the intracranial volume to rise. That can explain the rise in headache, the posture change. And vomiting, which causes a transient relief. We all know that with the vomiting, there is increase in the intrathoracic pressure that reduces the venous return to the heart, that reduces the cardiac output, and there is cerebral vasoconstriction, which temporarily reduces the intracranial volume, blood volume, and reduces the ICP. And it was associated with symptoms like hemiparesis and seizure. So we can say it that the headache was a secondary headache. Next one, please. So the second symptom was the visual symptoms. The patient had a positive visual phenomenon initially. The patient described that she was seeing some colored, vivid visual items. And then in 5 days, the patient had dimness of vision in both the eyes for near and the distant vision. So positive visual phenomena and negative visual phenomena both were present for our case. To localize that, we localize these things to the occipital cortex or visual cortex, and it has the primary visual cortex or V1, which is responsible for the light perception, and visual association cortex, that is V2 to V5, that is responsible for appreciating the color, the form of the object, and the movement of the object. So this positive visual phenomena initially was because of the cortical irritation locally, and then the dimness of vision was because of the negative visual phenomena, and it was a cortical dysfunction. Had it been the pre-chiasmatic lesion, it would have affected one eye, which is not in our case, which is not the case. And chiasmatic lesion usually described as a bitemporal field loss, though we understand that for a 10 years old girl, it is very difficult to describe the bitemporal field loss from the clinical history. We also uh, did the perimetry later on. We showed that there was a complete blindness in all the fields. And post chiasmatic lesions like cortical dysfunction can describe this. Bilateral posterior cortical dysfunction is the thing that we localize there. Next slide, please. Next one, please. So other symptoms of cortical involvement, the first one, right-sided hemiparesis, which happened priorly. So our possible levels of localization would have been left motor cortex or left subcortical white matter or the left-sided internal capsule or the brainstem above the decussation. So, given the primary symptom of visual cortex involvement or primary occipital cortex involvement, usually the occipital lobe involvement does not cause such motor deficit with upper motor neuron type of features. So, to cause the right-sided hemiparesis, the lesion must be big enough to extend anteriorly to the motor strip, or the edema or mass effect adjacent to the lesion should have encroached upon the motor pathways of the motor strip, or the venous congestion would have involved the deeper structures. That's why it can also cause the involvement of the motor strip. Next slide, please. So the pathway by which the edema can progress would have been parieto-occipital lesion to deep white matter to the posterior limb of the internal capsule and to the corticospinal tract, and it can cause the contralateral hemiparesis. Next slide, please. And for the left-sided focal motor seizures, which has been described for this time for this admission, the same explanation can describe all these symptoms. Either a new irritative cortical lesion has occurred, or the old lesion with the spread of epileptiform waves to the motor strip can cause this type of irritative syndromes or symptoms, which can present as focal motor seizures. Next slide, please. So for the differentials, we have a patient, a 10 years old child without any comorbidities, who was born to non-consanguinity, where the other sibling is doing well, and the patient presented with secondary headache, with vomiting, with cortical blindness, positive and negative phenomena, with history of right-sided hemiparesis 3 months back, and new onset left-sided motor seizures without any family history. So our anatomical localization was posterior cortical involvement, right parieto-occipital cortex now, and left parieto-occipital cortex earlier, along with the motor strip involvement. And to find out the etiologies, we have the recurrent strokes, which can be cardiovascular origin, prothrombotic state, metabolic strokes, or genetic strokes, or irritative lesions of both sides, or it can be cerebral venous thrombosis, or posterior reversible encephalopathy syndrome, or a multiphasic edema. Next slide. So we wanted to look at the previous investigations. The prior investigation shows that there was a hypodensity at the left parieto-temporo-occipital region with the mass effect, that was ischemia. Then the prior MRI also showed the T2 flare hyperintensity at that region and DWI restriction, and the AMR angio and the AMR venography at that time was also normal. Next slide, please. And now we have the opposite side of cortex, which is the right side of parieto-occipital, the right-sided parieto-occipital region on T1 having hypointensity. On T2, this is showing hyperintensity, and T2 flare is also showing intensity on the T2 flare. The DWI is showing restriction, and the ADC mapping is showing hypointensity in the middle, and peripherally in a gyral pattern there is a hyperintensity. So if the ADC is a mixture of vasogenic and cytotoxic edema. So this is the vasogenic edema peripherally and cytotoxic edema centrally. Next slide, please. But astonishingly, apart from those things we got earlier, the patient had a meningeal enhancement over the asymmetric meningeal enhancement over different regions, and along with that, the patient had a perineural sheath enhancement over both the optic nerves. Next slide, please. And this time also the vascular imaging, the venography was absolutely normal, and the MR angiography was absolutely normal. And the CT angiography was also done, which was absolutely normal in our case. Next slide, please. The MR angio of the neck vessels was absolutely normal. Next slide, please. So we wanted to rule out some cardiological causes for this patient. The ECG ruled out the rhythm abnormalities. The echocardiography was also done, which was normal, and the structural causes were ruled out. And the carotid Doppler also yielded nothing, and it was normal. Now the EEG was normal for our case, and the visual evoked potentials showed there were no waveforms. Next, please. So we wanted to exclude some recurrent infective cause, some metabolic cause, some hematological causes, and also wanted to exclude some demyelination if it is present. So we first did an CSF. The CSF opening pressure was normal, 70 millimeter of H2O. The cells were 3 per cubic millimeter, and 90% were mononuclear cells. Microprotein was 28 milligram per deciliter. Glucose was 62, which was normal, and CBNAT for Mycobacterium tuberculosis was negative, and at that time the blood glucose was 102. And for the hematological assessment, the patient had microcytic anemia, but the HPLC did not yield any pattern of thalassaemic traits or thalassemic disease, and the patient did not have any external features of thalassemia. The Sickling test was also normal, and the ferritin level and the inflammatory markers like ESR and CRP was also normal. Then the connective tissue disorder profile was also done, considering the recurrence of the symptoms. The ANA profile and ANCA profile was also negative. But astonishingly, the patient was showing positive result for the anti-beta 2 glycoprotein IgM panel, though other markers like lupus anticoagulant was negative. The vasculitis panel was negative. The thrombophilia panel again showed a low protein C and S activity, and antithrombin 3 activity was normal, and factor 5 latent mutation had no abnormality. Now, for the demyelination, though it is very unlikely to present, we also wanted to rule out because this is a pediatric case, so some cases may also be missed. So NMO and MOG antibodies were done, which were negative, and later on, the oligoclonal band and IgG index were also done, which was negative. To find out the metabolic causes, the patient's ammonia level was done, which was normal. Homocysteine level was normal, and the metabolic panel with TMS and GCMS was also normal. And the CSA biofire to rule out the infective causes was also yielding no result, and it was negative. The patient was because of the posterior cortical involvement and the visual loss phenomenon and the recurrence of the stroke like phenomenon, what we wanted to rule out the hyperlactatemia for this patient to rule out malus, and the serum lactate was done, which was absolutely higher, 3.75. The cutoff was 1.8, and the CSF lactate was sent. But in the meantime, we ordered an MR spectroscopy of the brain for this patient, which was done at 10 days after the clinical manifestation for the second time, and the MR spectroscopy of the brain showed a lactate peak. So next slide, please. So the derivations we got from our case was a childhood stroke, grossly diminished vision, normal MR or CT brain angioimaging, visual evoked potentials were absent, and the recurrent strokes which were spanning over non-territorial vascular pattern with high CSF and serum lactate and low protein CS activity with positive IgM beta 2 glycoprotein level. Next slide. So at this stage, the differential diagnosis we considered whether it is a mitochondrial or metabolic disease we are dealing with, or it is a prothrombotic state, or it is a CVD, or ADEM, or CNS vasculitis, or PRACE of normotensive variant. Next slide, please. So, starting from the less possible things, that trace of normotensive variant, we considered, we also included this thing in our differentials because of the posterior cortical symptoms, the seizures, and the visual disturbances that we have described. But then we expect an acute endothelial trigger with fluctuations of the blood pressure, only the vasogenic edema with ADC being high, and a reversible pattern. Even after 3 months, as you can see, 3 months back, there was only left-sided T2 flare hyperintensity. But even after 3 months, even with involvement of the right-sided parieto-occipital cortex, the left-sided parieto-occipital cortex is also showing non-reversible pattern, and there is T2 flare hyperintensity. So this is not a reversible pattern. So we cannot call it as RCVS or PRACE at this stage. And the patient had a mixture of the ADC being low, a mixture of cytotoxic and vasogenic edema, and it is kind of recurrent migratory episodes. And the patient had a CSF, serum lactate was higher, and the patient's MRI, even after 10 days after the initial stage of presentation, showed a lactate peak at the specific lesions. Next slide, please. Primary CNS demyelination, yes, though those there are some odds, but multiphasic course improvement in between, and the optic nerve signal changes on MRI and the area proxima like symptom and symptomatic cerebral symptoms led us to think whether we are dealing with some primary CNS demyelination. But the antibody levels were normal, negative, and the CSF protein was also normal. And the patient, as we described earlier, there is a cytotoxic edema that we are uh, dealing basically, and only the peripheral part is showing vasogenic edema. So this is a true diffusion restriction. So ischemia will be a major consideration than thinking of the demyelination. And MRI spine was also normal. So the antibody being negative, and there are so many odds with the case, we ruled out the NMOSD or Mogart spectrum of the disorder. Next slide, please. So CNS vasculitis was considered because of the multifocality of the cortical involvement and recurrence of the strokes. But as you know, for the pediatric patients, usually secondary CNS vasculitis occurs more, apart from the genetic ones. So we expect the vessel irregularity or bleeding or bayoneting, which is not seen in our case, and there are absence of the signs of systemic inflammation, and there is no CSF leocytosis. And with normal facial imaging, even after for repeated times, we have seen this case was evaluated 3 months back, and again this time also there were no facial changes as we have described in CT, MR angio of the brain and the neck vessels. So we can exclude it that we are not dealing with the CNS vasculitis. So next slide, please. Then cerebral venous sinus thrombosis, yes, it is considered because of the presence of headache, vomiting, and the visual symptoms. But in our case, there is no papilledema, no hemorrhagic venous infarcts, and the MR venography of the venous sinuses, so no flow void or turbulent flow. So this is not cerebral venous thrombosis at this stage. Next slide, please. So in the final stage, we have to pick up between these two whether there is a prothrombotic state which is causing up this recurrence of the stroke-like symptoms or a mitochondrial disease. Prothrombotic state was considered because the patient had presence of low protein and protein C as activity. It can occur in acute setting of the strokes, and there was the confusing factor was the elevated IgM anti-beta 2 glycoprotein level in our case, which usually suggests an underlying possibly prothrombotic tendency. But this elevation was very transient because to meet the criteria of the Apla syndrome, we have to get the IgM positivity of the beta 2 glycoprotein again after 12 weeks, which was done, and the repeat test after 12 weeks for that a particular antibody was normal. So we thought it was a transient phenomenon. And for the mitochondrial disease, we have different clinical pointers: the childhood recurrent strokes with lactic acidosis, and CSF lactate, which was sent earlier. It was 4.26. The report has already come, and it is 4.26, which is absolutely raised. And the stroke is not following any territorial pattern. So it is a non-territorial infarct. And the later on, we sent the genetics, as we have told it earlier, and the genetics also came months after, and it showed there is a pathogenic MTTL1 mutation, which confirms this is a Melas syndrome. This transient APLA positivity can be because of the secondary mitochondrial membrane damage. So next slide shows the CSF lactate level. This is 4.26. This is well above the cutoff of 2.2 that we have already described. So next slide, please. So the whole exam genetics that we sent, The whole exome genetics had no significant variant related to the prothrombotic state or the childhood onset genetic strokes. But the mitochondrial DNA analysis showed there is a specific mutation at the MTTL1 gene with adenine to guanine subbase change at the M.3243 base pair, and the heteroplasmy level was exceeding more than 2% in the blood, and in our case it was 72.6%. That explains the gravity of the clinical manifestation, the severity of the clinical manifestations we got in our case. So next slide please. So the treatment, we first started with aspirin and proton pump inhibitor, and IVMP pulse was given because of the optic nerve involvement, and the patient had the patient had lost the vision, and the patient was also given anti-epileptic drugs, and mitochondrial cocktail was started in suspicion of the child and in the background of the childhood stroke, which was presenting in a non-territorial pattern. Now, after a few days, the headache and vomiting subsided, and no further seizures occurred, and the patient had improvement in the vision after 10 to 15 days. Then the CSF lactate was higher. The report came, and then we withdraw the aspirin, and oral arginine was added. And in the meantime, months later, the mitochondrial DNA mutation came out to be positive. That also strengthened our diagnostic clues. Next slide, please. So, MELAS is a disease of maternal inheritance, which is inherited maternally. It usually affects or presents in a multi-systemic pattern. It involves the different systems of our body, and even in a same system, or suppose in the central nervous system or nervous system, it has different neuraxis. So, multi-axiality and multi-systemic presentation of the disease we have to always suspect for the mitochondrial diseases. Now, suspect MELAS for stroke-like cortical lesions that is migratory in nature and do not respect the vascular territories. This particular mutation that we got is seen in more than 80% of the cases of MELAS. And other mutations are also there, like MTND5, ND1, TH, TK, and TQ and TS1. So the basic pathology is that there is a mitochondrial dysfunction that initiates the cortical spreading depolarization because of the nitric oxide imbalance and lactic acidosis that increases the neuronal stress, and microvascular dysfunction occurs, cerebral perfusion decreases, and angiopathic changes also occur. So there is a set criteria for diagnosing MELAS for age less than 40 years of age group. The category one, the category A clinical manifestations are basically the clinical stroke-like features, which are present in our case: headache, vomiting, seizures, hemiplegia, cortical blindness or hemianopia, and acute focal brain lesion on the imaging. All were present in our case. Now, for the category B symptoms, that basically represent the mitochondrial dysfunction, elevated lactate in the plasma or CSF, or enzyme deficiencies, mitochondrial abnormalities on the muscle biopsy, and definitive mitochondrial DNA mutation. So, to prove that a case of MELAS, two from each of the categories should be present. At least two from each of the categories should be present. Now, our case satisfied all these criteria, excepting we didn't do a muscle biopsy for this child, but all other categorical features were present in our case. So, we stamp this case as a case of MELAS. Next slide, please. So, for this particular genetic abnormality, what occurs, there is a decrease in the mitochondrial protein synthesis that ultimately leads to the mitochondrial energy failure. And with this mitochondrial energy failure, the body will compensate by increasing the proliferation of the mitochondrial cells in the endothelial cells of the vessel wall. These are the major cells, or in the CNS. So angiopathy occurs and endothelial dysfunction occurs that impair the vascular perfusion to the different organs that cause the multi-organ damage. That is also because of the nitric oxide deficiency, which occurs in this particular genetic mutation of M.3243 adenine to guanine subbase pair change. And this nitric oxide deficiency in our body, basically the arginine mediated nitric oxide function is impaired, and it causes again a vasoconstriction symptoms, and the reactive nitrogen species also damages our cells. Next slide, please. So the purpose presentation of my case is that stroke is not always the cerebrovascular accident, at least in case of the pediatric population. Recurrent migratory stroke beyond the vascular territories in pediatric ages is a subset of the metabolic and mitochondrial disease. So, stroke in pediatric population is not always vascular. It can be metabolic, it can be genetic. When it is recurrent or migratory or beyond the vascular territories in pediatric age group, we have to suspect the metabolic or the mitochondrial disease. Posterior cortical syndrome in a child is not always PRES or RCPS, and the prothrombotic marker, if you get in pediatric populations, then it has to be repeated after 12 weeks for the proper diagnosis or stamping that case as an Aples syndrome. So, with this, I rest my case to my next speaker, my assistant professor, Dr. Jasodhara Chaudhary, madam.
I think my slides are also given. Can they be shared? Just I'll shortly say about a few points which are odd in this case and which need to be discussed. Can that be shared from your end, the support team?
Yes, give me a second.
So one thing, I think after the stroke, after this presentation, a very good presentation by our PDT. So the thing is clear that if it does not follow the arterial territory, we have to think of the other causes like mitochondrial, metabolic, even some genetic other causes of stroke, because pediatric stroke has got many etiologies which are not at all similar to the adult stroke. So here we could arrive that this is a mitochondrial stroke. Now, what were the odd pointers? Number one, there was preceded headache. So we will come to that eventually. Whether this headache and the migraine-like episodes or the stroke-like episodes can predict that this particular child, or even that for that matter, an adult will have a stroke. So that is a very important thing. So we repeatedly said that the optic nerve was involved. So this particular mutation in Miller's is a very unique mutation, that is a tRNA mediated mutation. And it has been shown that tRNA mediated diseases, especially in mitochondrial diseases, can lead to hyperintensities in the optic nerve or optic nerve affection. Why? Optic nerve has got very high ATP demand, and along with that mitochondrial dysfunction, if it is specially tRNA mediated, that leads to a failure of the oxidation system, and sometimes the optic nerve gets involved. So in this particular child, when we saw that the optic nerve was involved, for a matter we thought that whether it was a demyelinating disease. But on the back side, when we went back and did some research, we saw that due to this kind of pathophysiology, optic nerve can be well involved in mitochondrial diseases, especially those which are mediated by tRNA. Next slide, please. So another odd point, if you have seen during the presentation, meningeal enhancement. So a child who is having meningeal enhancement, is it common in mitochondrial diseases? That was actually, we have seen many Mellor's case or in fact Leigh diseases, but mitochondrial enhancement is not a very common phenomenon. But here, when we again went back and thought about this, so it is not a true meningitis. It is actually an energy failure driven vascular leakage. And of course, that caused cortical irritation. There was neck rigidity at that point in that child, which caused many kind of things that initially when the child presented, even meningoencephalitis was kept as one of the DDs that should be kept in a child. So this is due to the blood-brain barrier breakdown, the mitochondrial failure and capillary leakage, and that may lead to this kind of leptomeningeal enhancement. So whenever we see a leptomeningeal enhancement in a non-territorial pediatric stroke, we do have to think of a mitochondrial disease. Next slide, please. So also there is a very interesting link between this tRNA heteroplasmy and leptomeningeal enhancement. So, Dr. Debashish was talking about tRNA heteroplasmy and how it is very tissue specific. So, now the concept is, even if we don't get from blood the adequate heteroplasmy, if we do it from the tissue, we make it the heteroplasmic threshold crossing. And here exactly that happened. Because of the barrier breakdown, and there was endothelial ATP failure, there was vascular leakage, and that drove the meningeal enhancement. And this has been increasingly seen in those mitochondrial diseases which are mediated by the tRNA heteroplasmy. In particular, this mutation, this 3243 mutation, is always mediated by the tRNA heteroplasmy. Next slide, please. So I think that has been talked about. So I won't be saying this heteroplasmy is significant if it is in higher levels, especially in those tissues which are getting affected. And this particular mutation, this 3243, it causes strokes. Also, it may causes maternally inherited diabetes. So it all depends on which organ specific it is getting more expressed. So that is the new concept now in mitochondrial diseases. Next slide, please. So it is widely differing between the tissues, and there are, of course, we know in mitochondrial diseases in high demand tissues like muscle or brain, they are more expressed. And often, if we don't get from blood, we have to do a tissue specific analysis. That is one thing. If you are very highly suspicious of mitochondrial disease and you don't get anything in blood, we have to do a tissue specific analysis. That is another take home. Next slide, please. So mitochondrial headache, I won't be going into much details. We all know that this mitochondrial headache was the preceding harbinger of the stroke that happened. So is it possible? We had a discussion also. Is it possible from headaches, can we predict that this particular child or adult is going to have a stroke? So why this happens? Because there's a high demand brain regions are there, the parieto occipital, and if we know that the melas most oftenly affect the parieto-occipital regions, even in vascular insufficiency. Then there is high lactate, there is hyperperfusion, then also there may be episodic encephalopathy. And why this happens, there is nitric oxide dysregulation, because you know that the cycle is getting hampered because of the mitochondrial dysfunction. There may be a lactate accumulation that may lead to severe headache and vomiting, and of course ATP depletion. So there's a host of mechanisms and pathophysiology that is causing this mitochondrial headaches, and that mimics migraine. So it's very difficult to differentiate between the two, because that clinically almost always mimics the migraine like headaches, and it's called the MLEs, the migraine like headaches. Next slide, please. And we will skip this. The next slide, please. So what happens is there is the nitric oxide is getting hampered because the arginine. So that is the point why we should give in acute stroke or a severe headache caused by mitochondrial etiology an arginine infusion. Unfortunately, in India right now, arginine infusion is not possible. So what we did in an encephalopathic patient through Ryle's tube, we have to give arginine, which is easily available and quite well absorbed. Next slide, please. I think another few slides were given. So another point I'd like to mention was that stroke-like episodes. So the stroke-like episodes, these are the things that may happen here. And I think those slides, I sent it later. I think they could not get. So there is a beautiful thing that now it can be predicted from this stroke-like episodes. What are those? Nausea, vomiting, and intense headaches. And if they are persisting and even in a migraine-like patterns, they do have a different kind of radiological features, and that does not mimic the actual mitochondrial strokes. They may have an anterior pattern, may involve the temporal lobes. There is actually a pattern of stroke-like episodes in radiology as well as clinical. And if a child or a young adult gets those very frequently, we have to know that this may be a predictor for a mitochondrial stroke in future, and we have to start the mitochondrial cocktail at that point. This particular child was having headaches, and those headaches were ignored because they were thought to be migraine, and it's very difficult to diagnose. So I think we in future have to bring out a protocol that will help us to predict and then start the treatment early on. Now I'd like to request our HOD sir to sum up and give some valuable opinion.
Thanks to Dr. Joshodhara for your nice presentation and also the explanation of the odds which are seen. Hello, I think. Hello, I think
Sir, you're
I'm
audible.
audible. I'm audible to
Yes.
you. Yes.
Yes, you're audible.
So your nice presentation and the explanation by Dr. Joshodhara. And she also finally discussed about the different odds in our case. And also, I will also congratulate Dr. Our PDD, Dr. Debashis, for his nice deliberation. Now, I want to say some few points because after Joshodhara's speech, I think my task has been simplified. I want to say that when a patient, when a young that is child that is at the age of 10 years, a female child presented to us with recurrent episodes of stroke-like features with headache, with loss of visions, and one episodes of seizures. We thought that there is a possibility, and at the same time, the headache was holocranial headache initially, and we thought that possibly this headache and loss of vision is not due to the optic nerve involvement. It is possibly due to the bilateral involvement, that is bilateral parieto-occipital involvement is the main cause for this patient. So, and also at the same time, we have done the CSF study and the normal CSF, and also there is a normal fundoscopic finding. In our Dr. Devasis has already discussed the different differentials, the multiple differentials we during that time in our mind, and ultimately we have done the imaging, and from imaging we have seen that there is a non-territorial involvement of these stroke like features, and also there is a normal MR angio, and there is no thrombotic features, and also at the MR venography study is also normal. So we have already discussed, we have already that is negate the possibility of the that is CVT or the other causes of like that is thrombotic or cardioembolic stroke. We have already ruled out after doing the normal cardiological findings. So, but the thing is that the odd point is that there is a persistent initially during that time there is a decreased protein C and protein S, and also there is a anti beta 2 glycoprotein level is high, and so that we thought that possibly we are dealing also prothrombotic state that causes this thrombotic stroke, but actually MRI finding is does not correlate. And after 3 months, that is after 12 weeks, we have done this, and already it is negative. And same time we have also done the CSF lactate level, and also we have done the blood lactate level, and both are increasingly high. And there is a high level, and along with there is a MR spectroscopy was done, and there is a lactate increased lactate peak. So we thought that possibly we are dealing a case of mitochondrial disease, and so that we send the patient to the blood for genetic study, whole exome sequencing to rule out whether any genetic stroke is there or not, and at the same time there is a mitochondrial DNA analysis, and the report came to be a that is a mitochondrial DNA mutations, and we have seen that there is a heteroplasmy was more than 72%. That means there is a mutant DNA as well 72%, and also the normal is very less. So we already know that if there is a heteroplasmy more than 2%, that is pathological. Here is a heteroplasmy more than 72%, and there is a more chance of possibly of involvement in the brain rather than other areas. So considering this, we thought that there is a recurrent stroke is possibly due to high heteroplasmy. And already that we have seen that there is a mitochondrial TL1 gene, and there is a 3242 arginine 2 guanine, which is very much specific for MELAS. So we stamp the case of it is a MELAS. But the problem of during therapy, Initially, what we see that whenever the patient comes with that, there is a enhancement of the optic nerve sheath enhancement. Along with, we thought that possibly there may be some overlap between the immunological disorder along with this. So we had given this injection methylprednisolone initially, and for 3 days, very short period we had given, and the patient, the vision is completely recovered, and the headache is also subsided. And at the same time, we thought that there may be the possibility of there is a stroke-like feature. So whether there is any cardioembolic stroke or any prothrombotic state. So during that time, the report has not come. So we have started aspirin at the same time. But after getting this, all the reports after the genetic study, we already seen that possibilities we are dealing a case of MLS. So in that cases, we stopped aspirin and also stopped steroid also. And we had given a mitochondrial cocktail and also started arginine. For encephalopathic state, during that time that IV arginine, already Dr. Joshua has mentioned that IV arginine is not available in our country. So we have started through IELTS2, we have given the oral arginine, and the dose is about 0.2 gram per kg in divided doses. Until now it was continued, and the patient is drastically improved. His features, that is patient's cognition is much better. He can walk, he can run also. She can run also. And so we have continued at this moment, we are continuing this arginine. And this arginine, how does it work? We know that in mitochondrial disorder, there is the involvement of that, there is oxidative phosphorylation problem that leads to decreased ATP formation. And also at the same time, there is the mitochondria of the endothelial also affected. And so there is a problem of microvascular dysregulation, and resulting there is a causes of mitochondrial stress and increased vasoconstriction that leads to there is stroke-like features. So if we give arginine, how does it work? It works that it causes increased nitric oxide, the nitric oxide synthesis stimulation, and also at the same time citrulline. So we given that is alternative treatment may be given, either arginine, oral arginine, or maybe citrulline. But citrulline at this moment it is not available in all the metro cities, not in every metro city. So we started this arginine, and the patient is symptomatically better. And now, how long will continue this arginine? Now, the patient till now the patient is fine. There is no problem at this moment. But I think that arginine should be continued. In some literature, it has written that should be continued for lifelong. But here, if there is no, but in few literatures, it has written that if the patient has no recurrent stroke, and after 2 to 3 years, if there is no stroke, in that cases, there may be tapering of the arginine. So I think from our study, we are now starting this arginine, and we will have to continue this arginine. But after 2 to 3 years, if there is no stroke, but those can be minimized. That can be, for now it is getting 0.2 gram per kg. Then we'll reduce to 0.1 to 0.15 gram per day in divided doses. And the interesting thing is that after giving this arginine, the stroke features have completely gone away, and also the headache. There is no headache, and the patient is living a normal life. So in conclusion, I want to say that these type of patients, when a child comes with, because in children there is no involvement of what we see in mitochondrial disease, that there is a basal involvement, there is there are different types of mitochondrial disorders. I think this is a mitochondrial DNA and also nuclear DNA. That is a two type of DNA here. That is the mitochondrial DNA, that is a maternal from origin. So in that cases, our further approach should be that there is a genetic counseling is also required, particularly for this patient. Especially we'll perform her mother's mitochondrial analysis to be done. And also the other siblings, those who are not affected, their also mitochondrial study to be done at the same time. And next thing is also at the same time, our learning from this case is that when a patient comes with recurrent episodes of headache with stroke-like features or any seizures, and particularly headache patients, particularly young childhood headache patients. If there is severe headache, sometimes may come. There is no history of any migraine, family history of migraine. In that cases, I think there is a thorough search should be done, particularly to rule out whether we are dealing a case of any sort of any mitochondrial disease or not. Thank you. Thank you, Professor Lakshmi Narasimhan and Professor Sudhir Shah, for giving this opportunity, particularly in this academic platform. Thank you all.
Sir?
Dr. Lakshmi, would you like
Yes,
to
sir.
say
Yes, sir.
something?
Thank you. Thank you for a wonderful talk, and it's for the students, the exposition of mitochondrial disorders and the MELAs were exceptionally good. I just wanted to add one thing. Sir, where do this mitochondrial DNA come from? Mother or father?
The mitochondrial DNA coming from mother, and the
Yeah, sir. What is
nuclear
interesting is the mitochondrial DNA they have analyzed. The genomic content of mitochondrial DNA is neither present in mother nor present in father. It is essentially, even though it is maternally inherited, the genetic sequences are not from the mother, not from the father, sir.
Okay.
There is an endosymbiotic theory which says that this belongs to the prokaryotes. The bacteria, they have stolen sitting in the mitochondria, and they are the mitochondrial DNA as the sequences. None of the sequences in the mitochondria are present in the mother or father. They are inherited from the prokaryote. The prokaryotes, as they live in symbiosis with every cell, stealing the energy of every cell. There's an endosymbiotic theory of this, but just an interesting fact which I wanted to share with you. The mitochondrial genomic sequence is not from father or mother, sir. Even though the inheritance is maternal, the mitochondrial genome sequencing are there. So, and that makes it even more interesting that the bacteria sits in every cell and eats our energy, and whatever rest only we get. So it is essentially the microbes are dominating us in many ways. That's what I always used to wonder. And a wonderful case, sir. This MELA, especially the presenter and the madam, has really dissected the case very well, and it's a good expression. And thank you. And sir, any other comments from your side, sir?
I think the whole team complimented and bringing out this nice case. And as you have rightly mentioned, there are some misconception about the genetic material, but we have clarified very well. My point was sometimes the diagnosis can be made, at least suspected very nicely with the help of MRI itself. So when the patient with headache and seizures and focal deficit comes, and you a particularly young aged person, 15, 20, or maybe less, and then you find non-territorial lesions with diffusion restriction. If the ADC is normal or high, then one must start suspecting that there's something wrong, because in normal vascular stroke you get ADC low. Here it will be high or normal. The same thing, these non-territorial boundaries of the stroke or overlapping boundaries. So instead of MCA alone, the lesion would be extending beyond that. So that is another important clue. Then if you see there is some leakage or seepage, as madam was saying, there is meningeal kind of enhancement if you see properly. Then the MRS shows lactate peak. So and then the arteries are normal. So there are lots of clues from MRI. So if we carefully sit down and analyze with the radiologist and discuss out, sometimes we start suspecting very early rather than goofing around and going with a lot of interest, then coming back to this. So this might be a shortcut if we look at the MRI very carefully. So high or normal ADC with diffusion restriction is the first clue in a non-territorial lesion in a so-called focal neurological deficit with headache. In a young patient, it should give very, very high suspicion. That is what I wanted to reiterate. And of course, there is edema, cortical thickening also in acute phase, and later, of course, cortical atrophy occurs. The other important thing is that the lesions are migratory. I remember a couple of my patients who had initially left parietal lesion, and then on follow-up, let's say it comes to the right parietal or right temporal area, and then it disappears also. So not all those stroke leave their permanent I mean, uh, permanent atrophic lesions also. Some of them they disappear also. Some of them are large, some are small. So this is very funny and very typical MRI finding of this kind of MLS lesions. Lactate P is very important, and along with that, if you find in MRS reduce NA, then also it helps in diagnosing. So, MR spectroscopy is also important in such lesions. And when you do basal ganglia, CT scan, sometimes you find calcification. You know why basal ganglia is maximally affected in this kind of stroke. So, and the migration of the lesion over time. So, there are some things which give clue. Then subcortical lesions, white matter changes, which is not typical of, routine other strokes and lesions. So I think all have been discussed very nicely, but MRI part I thought I should highlight little more. So that is once again I must congratulate and thank Professor Karthik Ghosh and Madam Dashodra and Dr. Devashish Mehti for wonderful presentation and reminding the whole diaspora of neurology of this particular entity, which is often missed. Thank you very much.
Thank you, sir.
Thank you.
Dr. Lakshmi, anything else to add
Thank
from
you, sir.
clinical or
Good
other?
presentation. My hearty congratulations to the NRS team. They one of the reputed college, and Professor K.C. Ghosh is also very elite and very good academician, sir. I'm very happy that he's part of our neurological
Thank you, sir. Thank you.
My hearty thanks for him. Very short notice he has accepted, sir. My hearty thanks. And Dr. Yashodhara also, she did a wonderful job. And I could see young talents in Calcutta. The talents are very, very good, sir.
Sir, we are waiting for next
case. My
next
hearty
time.
congratulations to all of you.
Thank you, sir.
Yeah.
Thank you.
So somehow the representation from eastern part of India is less in this series. So you have made up this time. Thank you very much. And Dr. Lakshmi, do you have any idea which is the oldest existing medical college of India, whether it is from Chennai or Kolkata or Bombay?
Sir, they are difference by 1 day, sir. The difference is only 1 day. He went by train. He inaugurated the medical college in Madras. Started 1 day. 1 day before the Calcutta, they went by train, and then that started just a day difference.
Oh,
Yes,
Both
sir.
of them are
Yes,
300.
sir.
Which one? I don't know which one started first. One started 1 day early, one started late, sir. The train journey between the two stations there was a difference.
yeah, but it's
Okay.
very interesting and exciting to know that it's about 175-year-old medical college.
Sir,
That's
Madras
great.
Madras Medical College. The government general hospital is 375 years old. 1600.
So, apart from science of neurology, we are always interested and fascinated with the history
Sir,
of
one more
neurology.
interesting thing, sir. Sir, one more interesting thing is the dean of medical colleges. They were also the curator of museum.
Yeah, that time it was a pattern. Yeah.
I don't know why the museum was linked to medical college deans. I don't understand what is the sanctity behind it. And sir, the Ronald Rosewall, dean in Madras Medical College, sir. At least 2 Nobel laureates were part of in the dean's board, I can see those two Nobel laureates also.
Right.
Thank you, sir.
So,
Thank you. Good night. Good night, everyone.
Good night,
thank
sir.
you very much. Good night.
Thank you.
It
Hello.
was a feast from Dr. Ghosh. Thank
Yes.
you once
Yes.
again.
Welcome, sir. Welcome,
Thank you,
sir.
Dr. Jashodhara. Thank
Over
you so
to
much.
Thank you.
Diksha, you
Thank
want
you.
to say anything?
Yes, sir. As we come to the end of the today's episode, on behalf of Intas Pharma, we extend our gratitude to the entire team of NRS Medical College, Kolkata. Our sincere gratitude to Dr. Debashis for this structured case presentation and Dr. Jashodhara Chaudhary for his valuable insight, and to the Dr. Karthik Ghosh for his clear concluding remarks. We also extend our gratitude to our course director, Dr. Sudhir Shah sir, and Dr. Lakshmi Narasimhan sir for their continuous guidance and leadership, and at last to all our viewers for their continuous support. So we looking forward to see you all in the next episode of Secrets of Neurology. So thank you all.
Thank you.
Thank you.